Hi guys, welcome to the Acute Medical Unit. The AMU is a resource-intensive unit that aims to expedite the process of diagnosis, definitive treatment, and disposition. There are 4 places a patient can go from the AMU. Home. About 50% of patients are discharged directly from the unit. Keep. Patients can be kept in the AMU for up to 3 days. This is for patients who anticipate a short stay or waiting for investigations that might affect admitting specialty. Transfer to another hospital. For patients needing inpatient rehab, AMU has SLH Fast Track that can transfer patients the same or next day. Patients who don't require surgical or specialist review can be admitted to AH general wards. Patients who require inpatient palliation may be suitable for AH supportive care wards. This requires a NUH palliative care referral to assess suitability. Finally, admission to a UMC subspecialty of your team's choice. This is usually the least preferred option due to the long bed wait. Very often, during morning rounds, patients are not yet confirmed or KIV for discharge, provided certain criteria are met. For example, if labs improve, scans are okay, temperature or symptoms resolve, and importantly, if PT clears. Now, the quicker patients leave the unit, the quicker patients enter. We like patients to leave early in the day so that new ones come in during office hours, avoiding a surge of 15 new admits to see during morning rounds. As you can see, many things are happening in the AMU and many people are involved. Therefore, communication and clear documentation are extremely important in the AMU, and we have some special workflows too. Let's go through them. Only order labs that are necessary. Don't order fasting labs. Non-fasting lipids and HbA1c are usually sufficient. All scans except X-rays and CT brains need to be called for. Call the on-call radiologist for CTs, and if approved, then call the EMD radiographer as we use their machine to expedite scans. All procedures such as LPs or joint taps must be ordered and completed in Aurora for tracking. Changes such as referrals should be done as the rounds progress rather than at the end. For treatment, apart from medication, most of our patients need physiotherapy. Let's help them prioritize who to see first. There's no need to order OT. PTs will assess and refer to OT if required. And don't order PT if the patient is already walking around AMU, medically unfit for rehab, or already bedbound with competent carers. In fact, for these frail patients, please complete the AMU Frailty Bundle in the CDoc within 24 hours of admission. It will prompt you to think about confusion, constipation, polypharmacy, and think care status. Quick reminder, do discuss care status and offer ACP for patients with poor premorbid conditions and/or one or more irreversible organ dysfunction, such as severe ischemic or valvular heart disease, lung disease like stage 4 COPD, ESRF not for dialysis, advanced cirrhosis not for transplant, advanced neurocognitive disorders, and metastatic cancers on best supportive care. For disposition, during morning rounds, identify patients who are KIV home today. These patients usually require urgent input from Allied Health and are highlighted with an orange heart. Hang these cards above the patient's bed during AM rounds to provide a visual representation to all working in the unit. For these patients, confirm prescriptions early, even before they are confirmed to be home. All CDoc entries for patients in the AMU must include the AMU Care Plan template. This should be updated every entry and changes to disposition reflected promptly. It is available on the intranet and most desktops. After morning and afternoon rounds, teams must huddle in front of the AMU Progress Board. This board helps to communicate to Allied Health, nurses, and ward clerks about the patient's plan. For reviews, red magnets indicate urgent reviews, blue magnets indicate non-urgent reviews. In the disposition column, orange indicates KIV home, and green indicates home. For example, if a patient in bed 1 is KIV home if PT clears, then after clearing, the PT changes the red magnet to a green magnet, and then this patient is ready for home. This board should also be updated as rounds progress. The earlier the red magnet gets put up, the faster the relevant reviews will happen. Finally, AMU lodgers in the ED should be reviewed at 11 AM and 3 PM daily for those who have been waiting for more than 2 hours. This is led by the team SR, but may call on juniors to assist if the load is high. In summary, let's all work together to achieve quick diagnosis, treatment, and disposition, and provide great care for our patients. AMU is fast-paced, fun, and a great learning environment. Enjoy your time with us, and thanks for watching.